Good day. Today we are talking about seizures. A seizure is an episode of abnormal neurologic function caused by inappropriate electrical discharge of brain neurons. Neuronal electrical discharge, in its most simple form, can be thought of as the homeostasis of glutaminergic or excitatory and gamma-aminobutyric acid or inhibitory activity. The seizure is the clinical attack experienced by the patient in the setting of inappropriate excitatory activity. Some patients with epileptic EEG discharges may not experience any overt clinical symptoms. Some seizure-like episodes may be due to causes other than abnormal brain electrical activity, but such attacks are not true seizures. Epilepsy is a clinical condition in which an individual is subject to recurrent seizures. It implies a fixed, more excitatory condition of the brain with a lower seizure threshold. The term epileptic does not refer to an individual with recurrent seizures caused by reversible conditions such as alcohol withdrawal, toxins, hypoglycemia, or other metabolic derangements. Primary or idiopathic seizures are those in which no evident cause can be identified. Secondary or symptomatic seizures are a consequence of an identifiable neurologic condition, such as a mass lesion, previous head injury, or stroke. Electrical stimulation of the brain, convulsant potentiating drugs, profound metabolic disturbances, or a sharp blow to the head all may cause reactive seizures in otherwise normal individuals. Reactive seizures are generally self-limited, and a reactive seizure is not considered to be a seizure disorder or epilepsy. There are further definitions of seizures based on clinical factors. A provoked seizure has an acute precipitating event within 7 days of the insult. An unprovoked seizure has no acute precipitating factor or may result from a very remote incident. Status epilepticus is seizure activity for greater than or equal to 5 minutes or 2 or more seizures without regaining consciousness between seizures, and refractory status epilepticus is persistent seizure activity despite the IV administration of adequate amounts of 2 anti-epileptic agents. The International League Against Epilepsy recommends dividing seizures into generalized and partial seizures. When there are inadequate data to categorize the seizure is considered unclassified. Generalized seizures are thought to be caused by a nearly simultaneous activation of the entire cerebral cortex, perhaps caused by an electrical discharge originating deep in the brain and spreading outward. The attacks begin with abrupt loss of consciousness. Loss of consciousness may be the only clinical manifestation of the seizure, as in absence attacks, or there may be a variety of motor manifestations, such as tonic posturing, clonic jerking of the body and extremities. Generalized tonic-clonic seizures, also known as grand mal, are the most familiar and dramatic of the generalized seizures. In a typical attack, the patient suddenly becomes rigid in the tonic phase, trunk and extremities are extended, and the patient falls to the ground. As the tonic phase subsides, there is increasing coarse trembling that evolves into a symmetric, rhythmic, or clonic jerking of the trunk and extremities. Patients are often apneic during this period and may be cyanotic. They often urinate and may vomit. As the attack ends, the patient is left flaccid and unconscious, often with deep, rapid breathing. Typical attacks last from 60 to 90 seconds. Bystanders generally overestimate the duration of the seizure. Consciousness returns gradually, and post-ictal confusion, myalgias, and fatigue may persist for several hours or more. Absence seizures or petit mal are very brief, generally lasting for only a few seconds. Patients suddenly develop altered consciousness without any change in postural tone. They appear confused, detached, or withdrawn, and current activity ceases. They may stare or have twitching of the eyelids. They may not respond to voice or other stimulation and may exhibit involuntary movements or lose continence. The attack ceases abruptly, and the patients typically resume previous activity without post-ictal symptoms. Patients and witnesses may be unaware that anything has happened. Classic absence seizures occur in school-aged children and are often attributed by parents or teachers to daydreaming or inattention. The attacks can occur as frequently as 100 or more times daily and may result in poor school performance. They usually resolve as the child matures. Similar attacks in adults are more likely to be minor complex partial seizures and should not be termed absence. The distinction is important because the causes and treatment of the two types of seizures are different. Partial seizures are due to electrical discharges beginning in a localized region of the cerebral cortex. The discharge may remain localized or may spread to involve nearby cortical regions or the entire cortex. Focal seizures are more likely to be secondary to a localized structural lesion of the brain. In simple partial focal seizures, the seizure remains localized and consciousness and mentation are not affected. It is possible to deduce the likely location of the initial cortical discharge from the clinical features at the onset of the attack. For example, unilateral tonic or clonic movements limited to one extremity suggest a focus in the motor cortex, whereas visual symptoms suggest an occipital focus. Bizarre olfactory or gustatory hallucinations suggest a focus in the medial temporal lobe. Such sensory phenomena, also known as auras, are often the initial symptoms of attacks that then become more widespread, termed secondary generalization. Complex partial seizures are focal seizures in which consciousness or mentation is affected. They are often caused by a focal discharge originating in the temporal lobe and are sometimes referred to as temporal lobe seizures. Complex partial seizures are commonly misdiagnosed as psychiatric problems because the symptoms can be so bizarre. Symptoms may include automatisms, visceral symptoms, hallucinations, memory disturbances, distorted perception, and affective disorders. Common automatisms include lip smacking, fiddling with clothing or buttons, or repeating short phrases. Visceral symptoms often consist of a sensation of butterflies rising up from the epigastrium. Hallucinations may be olfactory, gustatory, visual, or auditory. There may be complex distortions of visual perception, time, and memory. Affective symptoms may include intense sensations of fear, paranoia, depression, elation, or ecstasy. Because such seizures result in alterations of thinking and behavior, they were previously referred to as psychomotor seizures, but to avoid any confusion with psychiatric illness, the term complex partial seizure is preferred. As noted, a focal seizure may spread to involve both hemispheres, mimicking a typical generalized seizure. For the purpose of classification, diagnosis, and treatment, such attacks are still regarded as focal seizures. In some patients, the discharge may spread so rapidly that no focal symptoms are evident, but the correct diagnosis may depend entirely on demonstration of the focal discharge on an EEG recording. The classification of seizures, just to recap, include generalized seizures in which consciousness is always lost, tonic-clonic seizures, also known as grand mal, absence seizures, also known as petit mal, others which include myoclonic, tonic-clonic, or atonic seizures, partial focal seizures which include simple partial with no alteration of consciousness, complex partial with consciousness impaired, and partial seizures with secondary generalization, also known as the Jacksonian march. There's also unclassified seizures in the cases of seizures with inadequate information. When a patient presents after the event, the first step is to determine whether the episode was truly a seizure. We obtain a careful history of the details of the attack from the patient and any bystanders who witnessed the attack. We inquire about the physical description of the attack because witnesses may label the activity and mistake non-seizure activity as a seizure. Important avenues of inquiry include the presence of a preceding aura, abrupt or gradual onset, progression of motor activity, loss of bowel or bladder control, presence of oral injury, and whether the activity was localized or generalized, and symmetric or unilateral. We ask about the duration of the episode and determine the presence of post-ictal confusion or lethargy. Next, we determine the clinical context of the episode. If the patient is a known epileptic, clarify the baseline seizure pattern. If the attack is consistent with the previous seizure pattern, identify precipitating factors of the current seizure. Common precipitating factors include missed doses of anti-epileptic medications, recent alterations in medication, including dosage change or conversion from brand name, sleep deprivation, increased strenuous activity, infection, electrolyte disturbances, and alcohol, substance use, or withdrawal. If there is no previous history of seizures, a more detailed inquiry is needed. Symptoms such as unexplained injuries, nocturnal tongue biting, or enuresis suggest previous unwitnessed or unrecognized seizures. Ask about a history of recent or remote head injury. Ask about any previous similar episodes that may be suspect as seizures. Persistent, severe, or sudden headache suggests intracranial pathology. Pregnancy or recent delivery raises the possibility of eclampsia. A history of metabolic or electrolyte abnormalities, hypoxia, systemic illness, especially cancer, coagulopathy or anticoagulation, exposure to industrial or environmental toxins, drug ingestion or withdrawal, and alcohol use may point to predisposing factors. These include trauma, recent or remote, intracranial hemorrhage, be it subdural, epidural, subarachnoid, or intraparenchymal, structured CNS abnormalities, vascular lesions such as aneurysm and arteriovenous malformation, mass lesions such as primary or metastatic neoplasms, degenerative neurologic diseases, congenital brain abnormalities, infections such as meningitis, encephalitis, and abscess, metabolic disturbances, hypo or hyperglycemia, hypo or hypernatremia, hyperosmolar states, uremia, hepatic failure, hypocalcemia, hypomagnesemia, toxins and drugs, cocaine, lidocaine, antidepressants, theophylline, isoniazid, mushroom toxicity from Gyromitra species, hydrazine in rocket fuel, alcohol or drug withdrawal, eclampsia of pregnancy which may occur up to 8 weeks postpartum, hypertensive encephalopathy, and anoxic ischemic injury through cardiac arrest or severe hypoxemia. We obtain a complete set of vital signs and a point-of-care glucose determination. In the post-seizure setting, focus the initial exam on checking for injuries, especially to the head or spine, as a result of the seizure itself. A posterior shoulder dislocation is an injury that is easy to overlook. Lacerations of the tongue and mouth, dental fracture, and pulmonary aspiration are also frequent sequelae. We perform a directed, complete neurologic examination and subsequent serial examinations. Follow the patient's level of consciousness and mentation closely to avoid missing non-convulsant status epilepticus. A transient focal deficit, usually unilateral, following a simple or complex focal seizure is referred to as Todd's paralysis and should resolve within 48 hours. Clinical features that help to distinguish seizures from other non-seizure attacks include abrupt onset and termination. Some focal seizures are preceded by auras that can last 20 to 30 seconds, but most attacks begin abruptly. Attacks reported to develop over several minutes or longer should be regarded with suspicion. Most seizures last only 1 or 2 minutes unless the patient is in status epilepticus. Lack of recall. Except for simple partial seizures, patients usually cannot recall the details of an attack. Purposeless movements or behavior during the attack. And most seizures, except for simple absence attacks or simple partial seizures, are followed by a period of post-ictal confusion and lethargy. Many episodic disturbances of neurologic function may be mistaken for seizures, which are known as seizure mimics. Paroxysmal disorders that are differentials for seizures include seizures itself, syncope, pseudo seizures or psychogenic seizures, hyperventilation syndrome, migraine headaches, and movement disorders. Syncope usually presents with prodromal symptoms such as lightheadedness, diaphoresis, nausea, and tunnel vision. However, cardiac syncope may occur suddenly without any prodromal warning. Syncope may be associated with injury, incontinence, or even brief tonic-clonic activity. Recovery is usually rapid with no post-ictal-like symptoms. Pseudo seizures can be extremely difficult to distinguish from true seizures and may occur in a patient who also has a documented seizure disorder. Pseudo seizures are psychogenic in origin and are often associated with conversion disorder, panic disorder, psychosis, impulse control disorder, Munchausen syndrome, or malingering. We suspect the diagnosis of pseudo seizures when seizures occur in response to emotional upset or only occur with witnesses present. These attacks are often bizarre and highly variable. Patients often are able to protect themselves from noxious stimuli during the attack. Characteristic movements include side-to-side head thrashing, rhythmic pelvic thrusting, and clonic extremity motions that are alternating rather than symmetric. Incontinence and injury are uncommon, and there is usually no post-ictal confusion. Patients will often stop the seizure-like activity on command. Accurate diagnosis of pseudo-seizures may require prolonged EEG or video monitoring to demonstrate normal EEG activity during an attack. The lack of a lactic acidosis or elevated prolactin level drawn within 10 to 15 minutes of the cessation of seizure-like activity makes true seizures much less likely. Hyperventilation syndrome can be misdiagnosed as seizure disorder. A careful history will reveal the gradual onset of the attacks with shortness of breath, anxiety, and perioral numbness. Such attacks may progress to involuntary spasm, especially carpopedal, of the extremities, and even loss of consciousness, although post-ictal symptoms are rare. Asking the patient to hyperventilate often reproduces the episodes. Movement disorders such as dystonia, chorea, myoclonic jerks, tremors, or tics may occur in a variety of neurologic conditions. Consciousness is always preserved during these movements, and the patient can often temporarily suppress the movements. Migraine headaches may be preceded by an aura similar to that seen in some partial seizures. The most common migraine aura is the scintillating scotoma. Migraine headaches may also be accompanied by focal neurologic symptoms such as homonymous hemianopsia or hemiparesis. However, active movement disorders are inconsistent with migraine. Individualize the use of laboratory studies. In a patient with well-documented seizure disorder who has had a single unprovoked seizure, the only tests that may be needed are a glucose level and pertinent anticonvulsant medication levels. In the case of an adult with a first seizure or unclear seizure history, more extensive studies are usually needed and depend on the clinical context. Obtain serum glucose, basic metabolic panels, lactate, calcium, magnesium, pregnancy tests in those who are assigned female at birth, and toxicology studies. Consider assays for anticonvulsant drug levels. A seizure may result in a lactate-driven, wide anion gap metabolic acidosis. Most lactate abnormalities will clear within 30 minutes. The prolactin level may also be elevated for a brief period of 15 to 60 minutes immediately after a seizure. These tests can prove helpful in distinguishing true seizures from a pseudo seizure. We interpret the results of anticonvulsant levels with caution. If patient history is limited, a positive serum assay for anticonvulsant drugs suggests but does not prove the presence of a chronic seizure disorder. The usual therapeutic and toxic levels indicated in a laboratory report are helpful only as rough guides. The therapeutic level of a drug is the level that provides adequate seizure control without unacceptable side effects. A marked change in previously stable drug levels may indicate non-compliance, a change in medication, malabsorption of a drug, or ingestion of a potentiating or competing drug. A very low serum anticonvulsant drug level suggests non-compliance with medication and is the most common cause of a breakthrough seizure. We obtain a CT scan of the head in the emergency setting for patients with a first ever seizure or a change in established seizure patterns to evaluate for a structural lesion. A non-contrast CT is an appropriate screening tool. Obtain a CT scan if there is any concern for an acute intracranial process based on history, comorbidities, or findings on physical exam. Concern for an acute intracranial process is an important indication for obtaining CT imaging even if there is a coexistent metabolic process. Because many important processes such as tumors or vascular anomalies may not be evident on non-contrast studies, a follow-up contrast-enhanced CT or MRI is often needed. Almost 1/4 of adults with new onset seizures will have visualized pathology on follow-up MRI, with rates increasing to as high as 53% in those with onset of a focal seizure. The timing of further imaging studies can be discussed with the consulting neurologist. We obtain other radiographic studies as indicated by the clinical presentation to avoid missing injuries acquired as a result of the seizure. Obtain radiographs of the cervical spine if there is suspicion of head or neck trauma. Chest radiographs may reveal primary or metastatic tumors or aspiration. Shoulder radiographs may help rule out posterior dislocations. Special examinations such as cerebral angiography are rarely part of the evaluation. Lumbar puncture in the setting of an acute seizure is indicated if the patient is febrile or immunocompromised or if subarachnoid hemorrhage is suspected and the non-contrast head CT is normal. Although EEG is very helpful, it is often not readily available in the emergency setting. Emergent EEG can be considered in the evaluation of a patient with persistent, unexplained altered mental status to evaluate for non-convulsive status epilepticus, subtle status epilepticus, paroxysmal attack when a seizure is suspected, or ongoing status epilepticus after chemical paralysis for intubation. Patients in whom an emergent EEG is warranted typically require neurologic consultation and admission to a critical care setting. For uncomplicated seizures, in patients with active seizures, little is required during the course of an active seizure other than supportive and patient protective measures. If possible, turn the patient to the side to reduce the risk of aspiration. It is not usually necessary or even possible to ventilate the patient effectively during a seizure, but once the attack subsides, clear the airway. Suction and airway adjuncts should be readily available. It is not necessary or recommended to give IV anticonvulsant medications during the course of an uncomplicated seizures. Most seizures will self-resolve within 5 minutes. Any unnecessary sedation at this point will complicate the evaluation and result in a prolonged decrease in level of consciousness. Seizures that fail to abate after 5 minutes are considered status epilepticus and require more aggressive medical interventions. Proper management of a patient with a well-documented seizure disorder who presents after one or more seizures depends on the particular circumstances of the case. Identify and correct potential precipitants that may lower the seizure threshold. Many seizures occur because of the failure to take anticonvulsant medication as prescribed. Some anticonvulsants have very short serum half-lives, and missing even a single dose may result in a sharp drop in serum levels. If anticonvulsant levels are very low, supplemental doses are appropriate, and the regular regimen can be restarted or adjusted. A loading dose is also frequently provided. Without a loading dose, the patient may not achieve anticonvulsant effects for days to weeks and is at risk for subsequent seizures. Because there are no data comparing parenteral versus oral replacement, the issue is left to the discretion of the medical provider and should be based on knowledge of pharmacology. For example, the oral loading dose of phenytoin is 20 mg per kilogram given in 3 divided doses every 2 to 4 hours, a time frame that is not acceptable for a typical emergency stay, so the intravenous route is needed to achieve the proper loading dose. In the known or suspected non-compliant patient, we obtain a serum anticonvulsant level before administering a supplemental or loading dose to avoid drug toxicity. If an anticonvulsant levels are inadequate and the patient has had a single attack, specific treatment may not be needed if the seizure pattern and frequency fall within the expected range for the patient. If anticonvulsant levels are not locally available, for example, levetiracetam or lacosamide, and there is a missed dose or non-compliance, we give the usual dose before discharge. Even well-controlled patients may have occasional breakthrough seizures. Attempt to identify any precipitants or conditions that have lowered the seizure threshold. If none are found, a change or adjustment of medication may be needed and should be made in consultation with the patient's primary care physician or neurologist. If the maintenance dose is increased, ensure follow-up within 1 to 3 days. There are no specific guidelines for the duration of observation in the situation of an individual with a prior history of seizures. Some clinicians discharge patients with seizures resulting from non-therapeutic anticonvulsant levels after administration of a loading dose of an anticonvulsant if vital signs are normal and the mental status has returned to baseline. Ideally, discharge patients with a reliable family member or friend and with medical follow-up arranged. For patients with a first unprovoked seizure, guidelines do not recommend hospital admission or initiation of anticonvulsant therapy in the patient with the first unprovoked seizure as long as the patient has returned to neurologic baseline. The most important predictors of seizure recurrence are the underlying cause of the seizure and the results of the EEG. The decision to begin outpatient treatment with antiepileptics depends on the risk of recurrent seizures weighed against the risk-benefit ratio of anticonvulsant therapy. In general, patients with the first unprovoked seizure who have a normal neurologic examination, no acute or chronic medical comorbidities, normal diagnostic testing including non-contrast head CT, and normal mental status can be safely discharged from the ED. Initiation of antiepileptic medication may be deferred to the outpatient setting where further studies including an EEG and MRI can be performed. Consider consultation and/or admission for patients who do not meet the above criteria. Patients with provoked or secondary seizures due to an identifiable underlying condition often require admission and should be treated to minimize seizure recurrence. The ideal initial anti-epileptic regimen is a single drug therapy that controls seizures with minimum toxicity. If the treatment is initiated, drug selection is based on the type of seizure and should be done in consultation with a neurologist. Anti-epileptic agents such as valproate, lamotrigine, topiramate, levetiracetam, and oxcarbazepine are options for adults with new onset seizures. Consider developing common protocols between emergency medicine and neurology when treatment of new onset seizures is initiated from the emergency room. Instruct discharged patients to take precautions to minimize the risks for injury from further seizures. Swimming, working with hazardous tools or machines, and working at heights should be prohibited. Driving is prohibited until cleared by the neurologist or primary care physician. There are special populations for seizures, which include patients with human immunodeficiency virus, because mass lesions, encephalopathy, herpes zoster, toxoplasmosis, cryptococcus, neurosyphilis, and meningitis are seen more frequently in this population. These can all provoke seizure activity. We perform an extensive investigation for the cause of the seizure. If no space-occupying lesion is identified on non-contrast head CT scan and there is no evidence of increased intracranial pressure, perform a lumbar puncture to exclude CNS infection. If no explanation for seizures is found, obtain a contrast-enhanced head CT or MRI. For patients with neurocysticercosis, this is caused by a CNS infection with the larval stage of the tapeworm Taenia solium and is the most common cause of provoked or secondary seizures in the developing world. The most common form of disease is parasitic invasion of brain parenchyma and cyst formation. Over 1 to 2 years, the cyst degenerates and becomes fibrotic, leaving a focal area of scar and calcification. Seizures are the most common clinical manifestation of neurocysticercosis and most frequently occur as the parasite is degenerating. In 80 to 90% of cases, the lesions resolve within 3 to 6 months, leaving the patient free of seizures. Up to 20% of patients will continue to have seizures and require ongoing therapy with anti-epileptic medications. In most cases, neuroimaging in neurocysticercosis is non-diagnostic. CT or MRI may demonstrate a 1 to 2 cm cystic lesion with thin walls and a 1 to 3 mm mural nodule, which is the parasite, a localized area of ring-like enhancement with surrounding edema, a calcified lesion, or hydrocephalus. Definitive diagnosis relies on a combination of the patient's clinical picture, exposure history, serologic testing, and neuroimaging. Seizures in neurocysticercosis are typically controlled by anti-epileptic monotherapy. Definitive treatment of neurocysticercosis is controversial and highly variable depending on the number, location, and viability of the parasites within the CNS. Antiparasitics like praziquantel and albendazole and steroids are best initiated in consultation with an infectious disease specialist or neurologist. The management of seizures or control of epilepsy during pregnancy requires a multidisciplinary approach. Most seizures in pregnancy are not first-time seizures, and an initial evaluation is generally as discussed earlier, with the addition of an obstetric evaluation to determine gestational age and fetal well-being. When a woman beyond 20 weeks of gestation develops seizures in the setting of hypertension, edema, and proteinuria, the condition is defined as eclampsia. Magnesium sulfate has long been used to treat eclampsia with good results. In eclamptic women, magnesium sulfate infusion compared to diazepam and phenytoin resulted in a greater than 50% reduction in recurrence of seizures and a lower incidence of pneumonia, intensive care unit admission, and assisted ventilation. Seizures and alcohol use are associated through missed doses of medication, sleep deprivation as an epileptogenic trigger, increased propensity for head injury, toxic co-ingestions, electrolyte abnormalities, and withdrawal seizures. Benzodiazepines in doses sufficient to manage withdrawal symptoms will usually afford adequate protection from acute seizures. These doses are often very large and need to be given in an escalating fashion. Evaluate and treat the alcohol-abusing patient with a first seizure as any other patient with a first-time seizure. Status epilepticus can occur in patients with a history of seizures or can be a first epileptic event. The most common causes of status epilepticus include subtherapeutic anti-epileptic levels, pre-existing neurologic conditions such as prior CNS infection, trauma, hemorrhage or stroke, acute stroke, anoxia or hypoxia, metabolic abnormalities, and alcohol or drug intoxication or withdrawal. Status epilepticus is a single seizure more than or equal to 5 minutes in length or 2 or more seizures without recovery of consciousness between seizures. After 5 minutes, seizures are less likely to spontaneously terminate, less likely to be controlled with anti-epileptic drugs, and more likely to cause neuronal damage. Status epilepticus is a neurologic emergency, and treatment should be initiated in all patients with continuous seizure activity lasting for more than 5 minutes. As seizures surpass the 5-minute mark, dramatic changes occur at the cellular level. decreased expression and internalization of gamma-aminobutyric acid receptors, coupled with increased expression of both glutamine and N-methyl-D aspartate receptors, lead to a greatly diminished seizure threshold. The blood-brain barrier is also compromised, leading to CNS penetration of potassium and albumin, both of which are hyperexcitatory CNS chemicals. After 20 minutes, hypotension, hypoxia, metabolic acidosis, hyperthermia, and hypoglycemia are present. Additionally, cardiac dysrhythmias, rhabdomyolysis, and pulmonary edema can develop. After 2 hours of seizure activity, neurotoxic amino acids and calcium are released into cells, leading to permanent neuronal necrosis and apoptosis. The hyperexcitatory milieu makes standard anti-seizure therapies much less effective in seizure termination. In non-convulsive status epilepticus, the patient is comatose or has fluctuating abnormal mental status or confusion, but no overt seizure activity is present. The diagnosis is challenging and is typically made by EEG. Findings suggestive of non-convulsive status epilepticus include a prolonged post-ictal period after generalized seizure, subtle motor signs such as twitching, blinking, and eye deviation, fluctuating alterations in mental status, or unexplained stupor and confusion in the elderly. Epilepsia partialis continua is focal tonic-clonic seizure activity with normal alertness that most commonly affects the distal leg or arm. The goal of treatment for seizure control as soon as possible and within 30 minutes of presentation is as follows. For active seizures ranging from 0 to 5 minutes, we give supportive care such as IV access, monitors, maintain airway, oxygen, check point of care glucose, and provide IV glucose if indicated, and protect the patient from injury. For established status epilepticus, treatment goal is within 5 to 10 minutes. We can give IV Lorazepam 2 mg at 0.1 mg per kilogram or IV diazepam at 10 to 20 mg plus one of the following. IV fosphenytoin at 20 PE per kilogram at 150 mg per minute, IV phenytoin at 20 mg per kilogram at 50 mg per minute, and IV levetiracetam at 2,000 to 4,000 mg. We also consider intubation. For refractory status epilepticus, the treatment goal is to treat this patient in less than 30 minutes. We give IV midazolam, load with 0.2 mg per kilogram, then an infusion of 0.05 to 2 mg per kilogram per hour, or IV propofol, 1 mg per kilogram intravenously, then 1 to 10 mg per kilogram per hour, or ketamine 5 mg per kilogram per hour, or IV phenobarbital at 20 mg per kilogram at 50 to 75 mg per minute. We also intubate the patient, admit them to the neuro ICU, and continuously monitor this patient with EEG. If toxic ingestion is suspected as the cause of seizures, we proceed with gastrointestinal decontamination. We do not attempt lumbar puncture during status epilepticus. If bacterial meningitis or encephalitis is suspected, we start empiric antibiotic or antiviral therapy. Status epilepticus can induce a brief peripheral leukocytosis as well as a mild cerebrospinal fluid pleocytosis. Radiographic studies such as a CT scan will usually need to be delayed until seizures are controlled. One thing to note is that phenytoin is not compatible with glucose-containing solutions. The drugs most often used in the therapy of status epilepticus are benzodiazepines such as lorazepam or diazepam and phenytoin or fosphenytoin. Benzodiazepines are used in patients with continuous or very frequent seizures to temporarily control the seizures until more specific agents can be given. Compared to diazepam, lorazepam has a slightly slower onset of 3 versus 2 minutes, but a significantly longer duration of action of 24 hours versus 15 to 60 minutes, and is associated with fewer seizure recurrences. Fosphenytoin is a water-soluble prodrug of phenytoin that is converted to phenytoin in the plasma. Fosphenytoin has similar time of onset, effectiveness, and cardiac effects as phenytoin. It has much fewer infusion site reactions due to the lack of propylene glycol and ethanol as diluents. Fosphenytoin may be infused quickly, and for that reason, it is preferred over phenytoin. Dosing is expressed as phenytoin equivalents to prevent confusion. The loading dose is 20 phenytoin equivalents per kilogram, which can be infused at 150 PE per minute over 10 to 15 minutes. Fosphenytoin can also be given IM, which may be useful if the patient does not have IV access. IV Lorazepam is generally still considered the initial agent of choice. Valproic acid is effective but has serious side effects as compared to the other agents mentioned earlier. There's a black box warning for valproic acid in the United States for hepatic failure and pancreatitis, and valproic acid should not be administered along with phenytoin. The dose is 20 milligrams per kilogram IV. Levetiracetam is very effective, quick to administer, and has few interactions and side effects. The precise mechanism of action is unknown, but it may inhibit voltage-dependent calcium channels and facilitate gamma-aminobutyric acid inhibitory transmission. The dose is 20 milligrams per kilogram IV. Although it is not yet approved by the Food and Drug Administration for status epilepticus in the United States, it is rapidly gaining favor as a first-line drug for established status epilepticus. For refractory status epilepticus, this is defined as persistent seizure activity despite intravenous administration of adequate amounts of two anti-epileptic agents and usually exceeds 60 minutes. Various approaches to refractory status epilepticus have been suggested, as mentioned earlier. Overall, there are few controlled trials that strongly support a single agent or combination of agents. Current recommendations include propofol, midazolam, and barbiturates such as phenobarbital or pentobarbital given as infusions. Propofol is widely used. It's a lipophilic general anesthetic that has come into favor for refractory status epilepticus. It can be started as an infusion at typical rates of 2 to 10 milligrams per kilogram per hour and titrated up to effect seizure cessation. Propofol has the added benefit of a short half-life, allowing for quicker neurologic recovery after seizure control is achieved. At higher doses of more than 40 milligrams per kilogram per hour, patients are at increased risk for hemodynamic instability, including hypotension, as well as propofol infusion syndrome. Midazolam is easily titrated. It's a benzodiazepine, and it can accumulate in peripheral soft tissues, particularly with renal insufficiency, leading to a prolonged recovery period. Patients in refractory status may not respond to barbiturates, even if they are often given. Ketamine may also be considered as a third-line agent in refractory status epilepticus. Ketamine is an N-metyl-D-aspartate receptor antagonist and helps block the hyperexcitatory pathway, which is thought to be a greater culprit in refractory status epilepticus. Ketamine can be administered as a bolus dose of 0.5 to 4.5 milligrams per kilogram or as an infusion up to 5 milligrams per kilogram per hour. The reference, as always, is Tintinalli's Emergency Medicine. Thank you.